Well, thank you, Mr. Chairman, and thank you for the MLI team for inviting me to speak here. It's always a pleasure to come and talk about lung disease at the MLI. And I've been involved with the Uganda and lung problems since about 2012. And we first of all did a survey in Masindi province on the prevalence and risk factors of COPD, which was quite a good study in that it was quite big and quite influential. And at the end of that study, we found that 1 in 8 people over the age of 30 had spirometric evidence of COPD. And the main risk factor appeared to be biomass smoke. And so after that, we thought, well, we've got a problem. So we sat down with the health professionals, and there were many of the community healthcare workers who'd done this. We said, what are we going to do now? We've given you a problem. What are we going to do about it? And so they came up with 2 things. They wanted an awareness program about biomass smoke and the risk factors. And in the UK, I've been doing work on lung health programs to keep people's lung healthy from birth onwards. And so we did the first lung health program in Africa at the time. And we did the Train the Trainer program. And the other element, which they said, was we want something for people who've got a problem. People who've got established lung disease, what are we going to do for them? They can't afford medicines. Even if they can, half the time they can't get hold of them. Let's have some treatment. And so we set up the Pulmonary rehab program, which, as you know, is a non-drug treatment. And so that's the background to how we got here. So my presentation today is about post-TB rehab. And we're going to talk a little bit about post-TB as a disease, and then how does pulmonary rehab, what is it, and how does it fit into the potential for treating this disease. And so that's what we're going to do. So one of the things which hit me when I came to do rehab here was how big a problem post-TB lung disease is, and how most of the evidence was really old. So there'd be some evidence from miners in South Africa, there would be some other information from America or Canada, and some old studies in Japan. But there's very little proper data on what happens to people who've had TB, what's their outcomes, and particularly with HIV and multiple drug resistance. The patterns are changing. TB is not the same disease as it was. And so we don't know really too much is going on. And so we've done some work, and we estimate there's 200,000 patients with post-TB lung disease in Uganda who are symptomatic, and this represents about 1 in 5 patients who attend the outpatients in Mulago Hospital. And the main complications, as I'm sure you're aware, are the lung destruction, the cavitation and fibrosis, with bronchiectasis, and then the specific complications such as tuberculosis, which may need treatment, and then airflow obstruction, which is increasingly become apparent that that's a big problem, particularly in the MDR TB patients. But how does it affect on patients? One of the things about these guys is, and women, is that they have a lot of symptoms, but they have very little that is offered to them by the health services, and they'll spend a lot of money on a range of treatments, which may be cough medicines, it may be herbal, it may be all sorts of things, which don't work very well, or they may be given inhaled steroids or bronchodilators, and lots of antibiotics. And not infrequently, they're given TB treatment empirically, which probably is not going to help them, and is not going to help anyone really, if they haven't got active TB. The predominant feature amongst our patients was chest pains, severe chest pains. They couldn't sleep on one side at night. You know, it was quite characteristic. And the psychosocial impacts of this disease could not be underestimated. These people are isolated, they were shunned by their community. There's a lot of stigma because they had this TB treatment, they weren't better, and whatever it is they've got, we just don't want it ourselves. And so it wasn't just the lungs that was causing the problems, it was these other elements. So we looked at a little of the data, and you can see that in this study by Singh, 51 post-MDR TB patients, 80% had respiratory symptoms, nearly all had radiological sequelae, and a fair bit of obstruction or mixed in the lung function. We did a survey, so there was a WHO acute TB survey done in Uganda, and there were 40,000 representative sample across the country that was done. It was a huge piece of work, and they all had x-rays and everything. And we found that of those, about 2% had a history of post-TB, and of those ones who'd had TB, 50% were recording symptoms. So these weren't people who were going to doctors. These were just out in the community, but they'd had a previous history of TB. But half of them were symptomatic. Chest pains was very prominent, and nearly half of them had X-ray abnormalities. So most people who've had TB are going to have something left behind that's going to affect them. And there's so little evidence about it. The sort of symptoms they've got, this one came from Rwanda, of symptomatic people going to hospitals, and again, very high levels of symptoms in these ones of cough, hemoptysis in this, really quite a high percentage, 60% had hemoptysis, and smoking history and lower levels of education and poverty always have come up as predictors of bad outcomes for people with post-TB. Okay, and when we looked at the guidelines and we did a scoping review, how many guidelines had anything about post-TB? What happens to the patients after they've had TB treatment? 3 out of 212 guidelines. So the guidelines are about treating the bacteria, identifying it and treating it. They're not about the person once they've finished the treatment. And I think that is a massive, massive error. And so when we looked at what studies have been done on the prevalence and the management, about a third of the papers were on prevalence and predictors, and about 2/3 were on how to manage the disease, which were all about surgery or ventilation. There's nothing about the ordinary patients that we see in the clinics day in and day out. And clearly, if you've got aspergillosis or you've got obstructive lung disease, then you need some treatment for that. But management of post-TB as a disease is really poorly defined. And you'd be pleased to know that the International Union Against TB, the union is really working now. There's a working group on this, and they are trying to formulate some plans. So these are the big questions. How many patients get, after TB treatment, problems? What are the impacts of HIV and MDR? And a whole range of questions about what do we do for them? What do we tell patients? How do we avoid them getting that stigma? What's the role of steroids? Is that going to reactivate the disease, or is it necessary for treatment of exacerbations? Does anyone know? I don't. And there's lots of ineffective treatments they're getting, like cough medicines, antibiotics, which are inappropriate cough medicines, which cost them money, but gain them little. So we wanted to do this pulmonary rehab program, and pulmonary rehab is a non-drug treatment which is strongly evidence-based, it's low cost and high impact. And it's in all the guidelines. We'll come to that in a minute. But basically, what it involves is an individualized patient intervention based on a good assessment of each patient, and they have exercise and education with the idea of changing their behavior. And it's designed to improve their physical and psychological condition, particularly their exercise capacity and quality of life, and promote long-term strategies to keep them healthy. So most of the evidence comes from COPD, but actually pretty much any disease which has got fixed or progressive lung damage will be appropriate, providing the patient has disability. If someone's got no disability, there's no point in putting them into rehabilitation. Okay. But any of those diseases, it can be useful. There's a lot of emerging evidence now about interstitial lung disease, how beneficial it is, even if they're on a steep decline. So the two major components are educating the patients. So what is the diagnosis? How do you make it? What does it mean? What's actually going on in the lungs? About the role of smoking and stopping smoking. What are the role of drugs, or the limits of drugs? And then there's physiotherapy, occupational therapy, nutrition, psychosocial. So there's a range of different things we go through with the patients. But most of the patients know very little about their lung disease. They are on their own with it. And a lot of the education comes from other patients. They talk to each other in groups. And that's quite interesting, seeing that interaction. And we give them an exercise program. So the evidence for this is really very clear, that it is impressively good at improving quality of life, however that's measured, and exercise capacity. And the Cochrane review has said no more trials of whether pulmonary rehab works. It does. We can do some studies to look which bits, how long, or where you apply it. Particularly implementing it in low-income countries, where we've been operating for some time now. The process of trying to set up a rehab program, you have to understand that unless you can get the patients referred, you've got a problem. And then you do a proper assessment, so you're making sure the diagnosis is correct, you're not missing anything. No point in giving someone pulmonary rehab when they've got lung cancer, and that's actually the underlying big problem to be sorting out. You make sure they're on optimal treatment, you measure their impairment, their comorbidities, make sure they're safe to undertake an exercise program, and then you enroll them, and they can be done in a variety of settings, but in this country it's largely going to be in the hospital settings, in physiotherapy departments, I suspect. Potentially there is a lower grade form of rehab which could be done in community settings, but that hasn't been looked into in any great detail. So we have to define the duration and frequency. So our programs are characteristic 2 hours twice a week for 6 weeks, but it may be that we could change that. And as I said, we've got exercise training and the education components. We have a lot of problems on the referral of patients because the doctors in many areas don't know that rehab is a good idea or that it's available. And so people go to their GP and they say, maybe I can go to this rehab program, and doctors are saying in many countries, you can't go to the rehab program, you can't take exercise because you've got chronic lung disease, don't be stupid. It's going to make you ill if you take exercise. And there are many doctors who have that view. It's dangerous to exercise. If anything that we take home today, it's that exercise is what they have to do to stay alive. So then we have to invite them, give them appropriate information, and have a referral form, which means we can get people in with the right information. We need to make it accessible, and so it's got to be at the right time of day when people can turn up for it. You've got to have transport, you've got to have appropriate languages considered, but it's got to be integrated into your local services. It can't be a standalone program, which then probably stops and nothing's changed. It's got to be integrated into the hospital services, so when people are in hospital, they say, oh, when you go home, you need to go on the rehab program. People understand this. Okay, when we assess them, obviously we do their standard demographics, including spirometry. When we're looking about their outcomes, we want to know about their exercise capacity, so we do a maximum exercise capacity test, and that's the one which goes bleep all the time. Bleeps get faster when you're walking between a 10-meter gap. Do you know what I'm talking about? Yeah. So this is the incremental shuttle walk test. It actually needs some degree of training of your physios or whoever's doing this test. You can't just give them tape and say get on with it, otherwise they'll make mistakes. We interested in their quality of life, so they had questionnaires around that, questionnaires about their breathlessness. We measured, particularly in this country, Karnofsky score, and in other countries. And there are other things you can measure. Self-efficacy, for instance, is one of the things you can measure. As I said, 6 weeks or more, twice weekly, I actually think we could probably bring it down to once weekly, which is half the cost to the patient and half the cost to the staff. I think that would work quite well. We need to train people to do this, and that usually requires a 1 week, fairly intensive training, a very practical training. And now that we've got the centre at the MLI, we can actually train people on site on how to do this. And then we can assess their competence to deliver. But say if we want to have a centre in Gulu doing this, what you'd actually need to do is to train the staff, but then you need to go to Gulu to have a look at the room they've got, the equipment they've got, the way they're operating as a team, to make sure that actually their competence as a whole team is there. Okay? And we share protocols, we share documents, so everyone's using the same systems, and obviously if you share outcomes, then you can compare your results to everybody else's. And as part of our work, we have now an international database which is collecting rehab data from probably about a dozen countries. And so you can benchmark. And also it's quite a useful database for us from the research point of view. So, a picture's from Kyrgyzstan. Sorry, it's not a Ugandan picture. The equipment you need for this is actually quite simple. So pulse oximeters, you need to be able to weigh and measure them, stopwatches for timing. Actually, most people use their phones for timing now. A few weights. If you haven't got weights, we use bottles of water. As you can see, she's got a 2 kilogram weight there. Okay, half full is 1 kilogram. And that's what we use in those centres. Okay. Emergency equipment, you do need to have oxygen in case anyone collapses, although it's very, very rare for that to happen. We need to have an education program for them. And if anyone has any questions about the education program, they ask this man here because he's done it 1,000,000 times. The chairman will answer those questions. Okay. So what have we done in terms of results? What does it actually do when we do this? So this is some data which we've got from different countries with low income, which we did for the Horizon 2020 program grant which we had. And we did implementation studies in different countries, and we got data from nearly 120 patients. Their diagnosis was, in this country, a lot of post-TB, and in Kyrgyzstan, a lot of post-TB. Other countries, it was more COPD and a mixed bag of asthma, interstitial lung disease, pulmonary hypertension, and all sorts of things. Median age 60 years, half female, 10% smokers. So what about the quality of life? Does it improve quality of life? The minimum clinically important difference on here is 4 points. You can see that over double that. That's a very good result when you compare that to sort of UK Western results. That's probably double what you'd expect. Why is that? It's because people have a pretty poor quality of life to start with, and they're very pleased to get something. And that's why patients here have come up to 240 kilometers on the bus to join the rehab program. So there's that. The MRC dyspnea scale, again, not a great sensitive measure, but again, it proves well above the minimum clinically important difference. So they're less breathless, and they're in a better state in terms of symptoms. This is how far their walking distance is. The improvement there was nearly 100 meters on a walking test, which is double the minimum clinically important difference. So that's a big result. That's much bigger than you'd normally see in Western studies. What about the things which people with post-TB suffer with? Chest pains. You can see that over 60% of the patients with post-TB had chest pains when they started. It fell dramatically. And at the end of rehab, when they did their pain scores, the median pain score was 0. It had fallen almost to 0 in most patients. So it's actually very powerful for improving chest pain. Why? We've got our theories, but I mean, you probably have your own theories as to why it would work, but nobody knows. But a patient gave me some useful information. She finished her rehab program, she came to a follow-up 6 weeks later, and I said to her, how are these chest pains? And she said, oh, it's so much better, doctor. And I said, but it's 6 weeks since you finished the rehab program. How come it's still working on your chest pains? And she said, it is my medicine for the chest pain. As soon as I stop doing the exercises, my chest pain comes back again. So patients will tell us this. And maybe it's because there's fibrotic bands pulling on the pleura, and maybe that gets stretched in the rehab, but nobody knows. And if you've got an idea, that'd be good. Cough didn't change much. Hemolysis was significantly reduced. Again, it's only theories as to why. But this was a big surprise to us, and I'd be interested if anyone has some comments on that. Qualitative data, we did extensive qualitative data in Uganda, and they told us just how important this disease was in their lives, how it was wrecking their lives in every way. Their relationships, their family, their ability to earn, the ability to eat, all sorts of things. And the improvements they got by attending rehab were quite transforming in their lives. There was a 16-year-old girl who'd had severe TB, had taken out one lung, the other one was badly damaged. And when she came to the rehab program, she was 18. And she was just waiting in the corner to die. She wasn't going to school, she had no prospects of marriage, no prospect of work, no prospects of anything. She was underweight, depressed, just sitting there. After the rehab program, she was back to school, she was back to being happy, she was back put on weight, she was strong again, she couldn't run far, but she could do everything else. And the family would say, you know, she can marry now. But, she says she wants to be a doctor, we'll find out. If you think about the impact of the disease, just to summarise the qualitative data, which is what they told us, you've got these things like the breathlessness, the tiredness, your physical inactivity, you become unfit, and that basically means you can't do so much. So you don't go out so much, you get socially isolated, then people start blaming you on things, blaming you for your disease and so on, and so they become more depressed. There are issues like they can't earn money, and then they've got treatment costs, and all these things work in a vicious circle. And what they told us when they'd had the rehab, you had improvements when they physically improved because they were not so isolated, they could contribute, they were accepted back in society more. Then they could earn some money, and then their mood improved, and then they were able to go out more. You can see how these things interact. So we think that people with post-TB lung disease have a real problem which is difficult to manage. We think that rehab can solve quite a lot of problems. Our data so far is really from implementation studies and qualitative data, but the benefits we're seeing are quite profound in however you measure. And we're now doing randomized controlled trials in the formal sense, and one is just about to start its first patient, we hope in the next week or two, which will be post-TB versus normal care. Post-TB having rehab versus normal care, just around the corner. And similar studies are being done in India, where it's culturally adapted, so they're using yoga and relaxing breathing techniques from traditional medicine woven into it. In Sri Lanka, they're using music and dance, as well as traditional medicine and things. And in Kyrgyzstan, they're very into their music and dance. So they have a culturally adapted program. And those are the studies which are going on at the moment, funded by the UK government. So in summary, we think PR is a real good option for people with post-TB lung disease in Uganda, and we hope that we'll see some more of it. Thank you.